Okay, now let's review the data for lurbinectedin in the treatment of small cell lung cancer. Let's start with the good, and the good is essentially the efficacy. Here we have the two studies that have been conducted and reported with the efficacy of lurbinectedin in small cell lung cancer. The first one was a basket study in which 105 patients with small cell lung cancer extensive stage were enrolled, and we have an overall response rate of 35.2%, median progression-free survival of 3.5 months, and median overall survival of 9.3 months, which in the second line setting for small cell lung cancer is pretty good, and essentially just puts this as one of the most efficacious treatments available for this disease right now. Now, the second study was a study in which lurbinectedin was investigated in patients that had had a chemotherapy-free interval of more than 6 months. And here in this setting, then the investigators saw an overall response rate of 60% with a median progression-free survival of 4.6 months and a median overall survival of 16.2 months. So that is the good. The efficacy looks actually pretty good. Unfortunately, the bad aspect of the use of this medication in small cell lung cancer is the myelosuppression. This is essentially a cytotoxic therapy and causes a significant myelosuppression with a grade 3 4 neutropenia rate of 41%, febrile neutropenia 7%. Since febrile neutropenia is less than 10% according to NCCN guidelines, then you don't necessarily need to give growth factor support to these patients. However, though, I mean, in my particular experience, then I have seen patients have like severe neutropenia episodes, and then so what I'm doing is if I see any risk factors for severe neutropenia, febrile neutropenia, then I go ahead and use prophylaxis in these patients, especially in elderly patients. Um, in regards to other myelosuppressive events, then we have a grade 3 to 4 thrombocytopenia rate of 10% and anemia of 17%. So that's the bad. Now, given the other options available, then we say that this is relatively not as bad as with the other options like topotecan. So it's really not that bad. But at the end, the takeaway is that clinical trials continue really to be the best choice for patients with small cell lung cancer in the second line setting. Now, these trials obviously then not they're not available everywhere, right? There are not a lot of trials going on anyway. So if they're not available, and as long as we're talking about chemotherapy-free interval of less than 6 months, then here we essentially have three choices, which is lurbinectedin, topotecan, and irinotecan. Now, that's as long as the patients have been treated with a PD-1, PD-L1 inhibitor in the first line setting in combination with carboplatin. And if that's been the case, then we have these three options. But as we have seen, really given the efficacy that I just showed you and the safety profile, lurbinectedin seems to me to be the best choice right now, what we have available. Even though, once again, I really don't like the myelosuppression here. I think it's just, I really just wish we had uh, a non-cytotoxic regimen available for the treatment of small cell lung cancer. Because in this setting, in the second line setting, it's just not a good thing to have these patients end up being hospitalized for with a severe neutropenic event like febrile neutropenia or sepsis. So anyway, so that's the main takeaway. So the opportunity here is essentially for drug developers to address this area of high unmet need and develop new therapies. This is a very attractive space because the standard of care therapies then have high toxicity and modest efficacy. So I think this is a good opportunity for development. And obviously the frontline setting is still a wonderful opportunity as well in this disease. So encouraging my colleagues to refer patients to enroll in clinical trials. All the fellows, then please enroll your patients in clinical trials. And well, with that, then that's it. Thanks so much. Bye.